Good evening to all the aspirants present here. The topic for today is Genito-Urinary Class 3. Our speaker is Dr. Anand Joshi, sir. He is a consultant intensive physician at Gamman Hospital, Hyderabad. Sir, you may take over. Thank you.
Thank you, Sana, and all the students. Welcome back to the third session. As in the beginning of the sessions, when we did the first two classes, we realized how extensive uh, and the detail is this HIV/AIDS and genitourinary sepsis there. We have touched the topics previously of the gonorrhea and other sexually transmitted disease, and then we had this elaborate class on HIV and AIDS. To be honest, a lot of physicians who practiced in 1990s and 2000, including me, learned a lot of my medicine with on HIV and AIDS patients, because there is so much to learn. There is so much of interaction, so much of infection, infectious disease things, opportunistic infections that comes across when we have a depressed immunity. Same thing holds true when you are dealing with a patient with a cancer or any other immunocompromised state. So I will just have a quick review that initially we went through this epidemiology, transmission, and clinical overview. We had uh, seen the routes of transmissions. We have understood the virus, how it is a double capsulated, it's got an RNA, and then how it is gifted with an enzyme called reverse transcriptase that enables it to go inside a host and then get embedded in its DNA and then break out and then come back. So this is what I was referring to. I think somebody is having a bit of a doodling. Then we have seen how the pathogenesis of HIV is primarily affecting the CD4 count, and it unleashes all the problems symptomatic as a primary virus and causing other inflammatory state. We have seen a bit of a natural history. We have seen HIV testing. We have understood what are the special testing considerations and few guidelines. We have seen previous talk, the clinical spectrum. It might be because of the direct effect of the primary HIV infection. We have seen how the immune dysfunction happens, and we have yet to see the opportunistic infection in detail. We spoke about age-defining conditions, not always the um, infection which is caused by HIV virus will present as a specific or discrete sign and symptoms, but they may come as a first infection or a cancer, which otherwise an immunocompetent person will never ever have. So when you get to see these infection, you need to think whether there is an underlying HIV/AIDS happening with this person. We have defined the AIDS, we have seen what the primary HIV infection is. We also have seen primarily how this HIV virus affects the organ system. It's a neurological effect, ocular, mucocutaneous, um, hematological, gastro, renal, respiratory, endocrine, cardiovascular, etc., etc. We have seen the management of HIV infected patient, and this was completely focused on antiretroviral therapy, because this antiretroviral therapy itself has so many side effects. So we need to carefully monitor them. Also, these people, as we know that viruses are very smart, so they would have a drug resistance, and we spoke about that. We spoke about how to initiate the ART, what are the goals of ART. We spoke about how the initial assessment of an asymptomatic patient, then monitoring of asymptomatic patients, how the viral load and CD4 count go up and down. We also saw about a sick HIV patient. Then we went through the classes of various medications, its regimes, its monitoring, its resistance, mechanism of drug resistance, drug interactions, etc. They also seen its complications and a special situation including immune reconstitution syndrome. Um, so we stopped at this slide last time, and then what were remaining were the opportunistic infection, specific infection, and malignancy associated with HIV, which I'm going to cover in today's talk. So if you understand closely that we know that the CD4 counts and some B cells gets infected. So that's basically in the current situation or scenario with this familiar term, our army, the body army is getting suppressed or getting destroyed. And so we are, our body becomes a country without any army, and that gets susceptible to all sorts of infection. You think often it is possible. We get bacteria, we get virus, we get protozoans, we get fungus, all sorts of things. However, this was true when we in the initial years in 90s and early 2000s, when highly effective antiretroviral therapy, also famously called as heart therapy, was not getting introduced. But with the introduction of the heart therapy, the things have now, before a person gets into severely immunocompromised or immunosuppressed state, we are able to balance his immunity out with heart therapy. But in bargain, what we have found is when a person is severely immunosuppressed and he gets an infection, the major body defense mechanism for our infection is the body's inflammatory response to any invading organism, whether it's a virus, whether it's fungus, protozoal, or bacteria. Now, in the presence of HIV, when these things are not there, and at the time of the diagnosis, if the patient is harboring this infection, then we have no clue whether this is primarily an HIV or there is an additional super added infection. That is because the body has not shown any response. There is no fever, probably there is no any symptoms. But when, or maybe there is some response which is not adequate. So what we saw that when these patients were given heart therapy and the HIV viruses came down and the immunity started restoring back, there was a sudden inflammatory response. And to a treating physician, it appeared that the patient is worsening. But that was not actually. This, they termed it as IRIS syndrome, that is immune reconstitution syndrome, which confused the physician who is treating an HIV that whether I am doing something wrong because things have started suddenly worsen. So this aspect needs to be kept in mind when you're treating any opportunistic infection, and this should be on the top of your mind when you're treating simultaneously HIV and the infection. As the common sense goes, if the patient is having an HIV and he is known case of HIV, immunosuppressed state, the prevention remains the cornerstone. So before we go to any individual infection, let's talk about the prevention. Obviously, personal hygiene, avoidance of any avoidance of the patient going in any area where the communicable diseases are very high. Hand hygiene is the most important thing you would be advising to any HIV patients. There are few guidelines for immunization, which I will show you in the next slide. Chemoprophylaxis has also revolutionized for certain infections. This is the primary and the secondary chemoprophylaxis, and it has shown that pneumocystic cerevisiae, toxoplasmosis, and Mycobacterium avium intracellularly, these organisms, when respond very effectively to the primary prophylaxis. That means the chances of the patient getting this infection is dramatically reduced if the patient has a primary prophylaxis. However, primary prophylaxis is not recommended normally for any herpes, fungi, or cytomegalovirus because it has shown not to be useful. So, whom should you give the chemoprophylaxis? As per the guidelines, any person, any HIV person, positive person whose CD4 count is less than 200 warrants chemoprophylaxis. So the 200 is the golden number you need to remember. I just spoke about the immunization. So as we know, this is a quite an immunosuppressed state. There are certain vaccines which can be given, certain vaccines which cannot be given, and certain vaccines which are like can be given in certain situations. So it goes unsaid that all inactivated vaccine can be given to HIV because your immune system is so poor, you cannot give a live vaccine to them, which is supposed to induce a memory cells. So you can't give that. So the first column tells vaccines that can be used in all the HIV patients, and they are all inactivated. That is Hep A, particularly Hep A, Hep B, influenza B, Japanese encephalitis, meningococcal, polio, rabies, typhoid, tick-borne anthrax, cholera. Cholera live vaccine, influenza live vaccine, polio live vaccine should not be given. So if you are confused, just remember that all the live vaccine cannot be given, whereas all inactivated vaccine can be given. Now, vaccines that can be used only in asymptomatic HIV infected adults with CD4 count of more than 200 are the MMR, varicella, and yellow fever. These are only three, right? So this is an important thing which you need to keep in mind, and even from the exam perspective. So let's check on to the specific conditions associated with HIV infections. So we'll start with a fungal infection. One of the most studied, talked about, spoken about are the PJP or PCP infection, pneumocystic carni, or the new name as it's no longer a new name now. It's a pneumocystic cerevisiae pneumonia. This fungal, or it's an actually a borderline fungal in terms of class, it's usually seen in when there is the CD4 count is less than 200. So this is subjected to the primary prophylaxis, and a good hard therapy would push the CD4 count above 200, and the infection or the infectivity goes down. This fungus actually damages the alveolar epithelium, reduces the compliance, and induces an ARDS-like picture. Patient's presentation is for any other pneumonia like shortness of breath, dry cough, fever, tachypnea, tachycardia, cyanosis, and you can hear either fine crackles or there could be absolutely no abnormality. Now, the thing about this PJP in the diagnostic is that the chest X-ray initial or the early infection may be absolutely normal. So you may be fooled by absolutely normal X-ray, and then the patient, and you will start thinking of a heart failure or some any other thing. But no, be careful when you're doing that. The another presentation might be either it's a normal or the chest X-ray might reveal over the period of time bilateral perihilar interstitial infiltrates, which eventually gets into a full-blown bilateral ARDS. These patients, when you do high resolution CT scan, they would reveal these ground glass opacities, and that would might be a diagnostic. Usually the diagnostic is by bronchoalveolar lavage or blood PCR. Sputum staining of the silver stain or the immunofluorescence would also reveal it. But most of the time we are doing either BAL, that's a bronchoalveolar lavage, or blood PCR. The treatment is simple with cotrimoxazole and for 3 weeks. The patient who are acutely hypoxic responds very well to the hydrocortisone standard dose. You don't need to pulse them, but the shortness of breath and the cyanosis responds very dramatic for these patients. Those patients who's got allergy to cotrimoxazole, trimethoprim, sulfamethoxazole, you have pentamidine, dapsone, atoquinone, plus minus clindamycin or primaquine. Chemoprophylaxis you can give as a cotrimoxazole 960 milligrams 3 times a day uh, for a week. The second important fungal infection is Cryptococcus neoformans, and the most common presentation in HIV patient. You can get Cryptococcus in other immunosuppressed state, but in HIV patient, they most commonly present as a meningitis. Otherwise, they can come as a pulmonary or a disseminated infection. Typically, this is acquired from the bird dropping, and history would give you a clue about the possible source of the infection. The diagnosis, you have to do a CSF. Infective CSF would be the picture, and you can have an India ink preparation, CSF antigen for a Cryptococcal neoformans, and the culture would reveal the organism. The treatment is a tough nut. It's an amphotericin B plus minus flucytosine or IV fluconazole for those who are in. But that's again, it's not a first line. First line is definitely an amphotericin B. Now, if the patient is not on heart and you discover Cryptococcus neoformans, try to hold your heart therapy at least for 2 weeks. First, treat the patient at least for 2 weeks and then start. Because if the patient is coming with a meningitis, with a headache, then starting a heart early would induce iris. And when the iris sets in, you may get worsening of the symptoms for the in terms of neurological manifestation. So be careful when you're trying to start a heart for a Cryptococcus neoformans, because at some point you will have to start it because the patient is severely immunosuppressed and you have to start heart. But when to start? Wait for at least 2 weeks. The third famous are the Candida infection. Now, the Candida infection, unlike just an oral thrush, it of course it comes as an oral thrush, but here it is involves right from mouth till down the whole whole colon. Commonly, we see it as an oral thrush. Along with that, we have an esophagitis and vulvovaginitis are the very common. Candida albicans are most commonly seen, but cruzi and the glabrata are the one which you should be aware, because cruzi, Candida cruzi is a fluconazole resistant. So even though you start treatment fluconazole, you think that you have covered Candida, but if it's not responding and you don't know the typification, and if it turns out to be Candida cruzi, then it's not going to work. Here, the prevention, again, you improve your CD4 count, decrease your HIV viral load with the heart treatment, and the candida infection will automatically be taken care of.